Good morning. The good news and the bad news is that we are all living longer. With Americans living longer comes a greater likelihood that we will suffer from memory loss and potentially Alzheimer's. Today's speaker, Dr. Jim Ellison, will discuss the concepts of dementia, memory loss, and Alzheimer's with some fascinating statistics. Dr. Ellison moved to Delaware in 2015 to become the first Swank Foundation endowed chair in the Memory Care and Geriatric Unit at Christiana Care. His objective in this role is to enhance the care of older adults with neurocognitive disorders in Delaware by increasing their access to state-of-the-art diagnostic tools, clinical assessment, and treatment approaches, caregiver support resources, and research trials. He is the editor-in-chief, the Journal of Geriatric Psychiatry and Neurology, and Professor of Psychiatry and Human Behavior at the Sidney Kimmel College of Medicine, Thomas Jefferson University. Please give a warm Westminster welcome to Dr. Ellison.
Thank you so much. Is anybody uncomfortable with my taking my mask off? Okay, I think I'm going to do that then. You'll hear me better. And I'm going to stand over here by the piano, but I promise not to sing. I'm going to talk to you for 20 or 30 minutes about Alzheimer's disease, and we'll leave time for you to ask questions. Anything you're interested in, we can address. I'm always grateful for the opportunity to talk to groups about this important topic. I've been spending the last few decades of my life devoted to it, but there's none of us who are not touched in one way or another by this problem of cognitive impairment, which, as Chip says, is inevitable as a consequence of the increased lifespan that we're enjoying. Next slide here, please. And this just says I have no financial disclosures to make, and if I talk about any drugs off-label, I'll be sure and mention that. Next slide, please. So to start with, you can do the next slide too. When we talk about cognition, it's important to think about what we mean by that. I work in a memory clinic. We call it a memory clinic because everybody thinks about Alzheimer's and other dementias as being memory disorders. But in fact, cognitive disorders, or what we call them now neurocognitive disorders, there's milder ones and more major ones, which I'll tell about later. They cover a range of cognitive functions, and when we talk about cognition, it's more than just memory, and these disorders affect much more than memory. Can you do the next slide here? And the next one. Yeah, I don't know if you can really see this very well, so I'm going to just tell you about it. So when we talk about cognition, which is our capacity to know what's around us and interact with the world, we're referring to now 6 special domains of mental activity. New learning and memory is, of course, very, very important. And when memory is failing, it's very clear to people that memory is not working. You can see people forgetting, having trouble remembering names, which, of course, all of us do after about age 30. But more serious problems, for example, one of my favorite patients in our clinic came to our attention when her husband brought her in. She worked in a restaurant. She made a turkey sandwich for some customer. She left out the turkey. This gets a little bit more serious. And people can forget very, very important things, like a grandmother who forgot to pick up her grandchild at school, leading to all sorts of complications and problems in the family. Memory failure is a very serious problem, but it's not the only thing. Sometimes even before memory starts to fail, we see difficulties with executive function. That's the ability to problem solve, to think abstractly, and to reason. And you can imagine how much difficulty that causes for people who are trying to continue to work, to manage their finances, to make good decisions about the scam that they're being tempted with, for example. Complex attention is another important area of cognition, and that's something we all do, multitask. Spread our attention from one thing to another thing and then try not to forget about the first thing. If you're cooking something and the doorbell rings, you can't leave the pot on the stove or problems could occur. Then there's visual spatial function, which is our ability to negotiate in space and understand the relationship between objects. And of course, one of the first and most tragic things that we see in people with cognitive disorders is that their driving starts to deteriorate. And when that happens, sometimes they have to be evaluated and even have their driving privileges restricted, which is devastating for people. Then there's language, which we divide into our understanding of what people are telling us and our ability to express what we want to say. And that can be separately affected beyond anything else in cognition. And then finally, there's social cognition. We don't think about that perhaps as often, but social cognition is that important skill that we all have and develop to be able to read other people's behavior and read their nonverbal communications with us, to understand what they're thinking, whether they mean us well or ill, to understand their emotions. And part of the reason that I take my mask off is because we learn so much from people's faces when we communicate with them and from their bodily gestures. And that can be disturbed and absent even in people with neurocognitive disorders. Next slide, please. So an evaluation in a place like the Swank Center, our memory disorders clinic, would think about all of those different types of cognition. Now, as we age, there are a number of ways in which our cognition actually improves. So it's no mystery or unfamiliar idea to you that we look to our elders for guidance, for wisdom. And what does wisdom represent? Well, from the neuropsychological standpoint, wisdom is what we call crystallized intelligence. It's the ability to use what we've learned through our years of experience to deal with a situation that we've encountered previously. If I know, for example, that working with one of my colleagues at the hospital is going to be challenging because of their personality being somewhat different from mine, I think about situations where I've been in the past that are similar, and I can base my behavior accordingly on that past experience and know what didn't work in the past. Fluid intelligence is something different. That's our ability to use new information and solve new problems that we haven't encountered before. It's not an accident that physicists are often awarded their Nobel Prize for work that they did in their young adulthood. As we get older, our crystallized intelligence remains and grows. Our fluid intelligence is less reliable. Next slide, please. Yeah. There are ways in which cognition deteriorates as we get older. Now, there are a number of things that start to happen even as early as our 30s when we start to have some trouble remembering the names of people we haven't seen for a long time. And we all joke about it. One of the reasons we joke about it is because it's pretty anxiety-provoking, especially if you've had relatives that underwent cognitive deterioration. And you start to think, well, what does this mean? Am I starting to lose it? There are other things that are very common cognitive slips, like what we call a failure of prospective memory. I walk into a room and I think, why did I come in here? You know. If you park in the same parking ramp every day, sometimes if you're distracted when you're parking, listening to the radio, talking on your phone, you enter the ramp at the end of the day and where did I put my car? I remember walking around the ramp at the hospital and a nurse walked by me and said, "You're lost, aren't you?" And I said, no, you know. Very sensitive about this, working with people who have this problem. Now, more serious disturbances of cognitive function, though, interfere with social and occupational responsibilities. And they involve things like changes in processing speed, I'm still going to talk about some of the normal changes. So processing speed is our ability to incorporate new information quickly. For example, what I often think of is when you ask somebody for directions and they start to give you a list of 7 or 8 instructions and your mind shuts off after about the 4th one. We all have had an experience like that, and I hope. And that kind of experience has to do with our ability to absorb new information very quickly, and that changes as we get older. So it takes a person who's older longer to learn new things. Working memory is the ability to keep things in your head and manipulate that information. We test that in the office with one of the most dreaded cognitive tests, the serial 7s, where we say, start at 100, subtract 7, keep on subtracting 7. And that ability to keep your marker on what was the last thing you said and then do the mathematical operation is tough for people, tough for everybody, and puts some stress on the brain. Next slide, please. The last thing there is sensory perception. And as we get older, it's not uncommon to experience some decrement in vision and hearing. The World Health Organization has just started to publicize what's been discovered in research recently, that hearing loss, it puts a person at risk for dementia. I witnessed this in my own family as my father, who had very acute hearing in his younger years, started to lose his hearing, but like many people, was resistant to wearing a hearing aid. It doesn't produce the same natural sound for some people, and there are many people who don't like that sensation. Not wearing the hearing aid, first he did what everybody does, say, what? What? Can you say that again? But that grows tiresome to everybody. So then people with hearing loss often pretend that they understand and nod and act like they're hearing, but gradually are tuned out more and more to the point where new information is not coming in, and that's a hazard. Now, next slide, please. What are the neurocognitive disorders? In other words, at what point does cognitive change in an older person become serious enough that we call it a disorder? And here, if you can see it, I've put on a spectrum a different listing of cognitive stages. Up at the top, I put supernormal because for the sake of all of our self-esteem, we want to put people in a special class if they have lost no cognitive functioning with aging. But typical or normal aging, as I talked about, includes some changes. Then there's what we call subjective memory impairment, and about 90% of people over 65 will say, if you ask them about it candidly, that they don't remember things quite as well as they used to, or think as quickly as they used to. That's normal. It needn't be a problem, but when a person identifies that they have that kind of a problem, they're putting themselves in a group that's a little bit more at risk for what comes next, which is mild neurocognitive disorder, which you sometimes hear referred to as mild cognitive impairment. Mild cognitive impairment is a measurable deficit on neuropsychological functioning. We can do tests like a connect the dots test, where a person is asked to connect 1 to A to 2 to B to 3 to C to 4 to D, and so on. We can even do that verbally, and it should be easy for most people to get up to 10 and J. That slows down and is problematic in mild cognitive impairment, as are some other cognitive changes. Sometimes memory is pretty well intact, but language expression or understanding is impaired, or complex attention is impaired. In any case, if we can see a significant testable change which doesn't interfere with the person's daily activities very much, we call that mild cognitive disorder. And the sign of that is a person has become usually more dependent on lists, yellow Post-its, reminders on their phone, having people remind them to do things. We call that compensatory behavior. And then finally, dementia is that last stage that affects 10 to 15% of people over 65 and about 45% of people over 85, during which a person is dependent on others for their basic daily needs. Next slide, please. Now, when we talk about dementia, can we do?
Sorry.
That's okay. When we talk about dementia, it's important to talk about how it relates to other diseases of aging. We've seen changes in all of the age-related diseases, such as cancer, heart disease, stroke. Another disease that's changed a great deal with advances in medical care is HIV. All of these disorders have decreased with the result that people are living longer, and as we live longer, age is the biggest risk factor for development of dementia. So dementia is actually increasing 63% over the past, well, between 2000 and 2010, and then it's continued to increase. So in contrast to other diseases associated with aging, dementia is more of a problem now. And it's estimated that in the United States, 6.2 million people have dementia. In Delaware alone, 19,000 people. Next slide, please. It's one of the top causes of death now. Dr. Alzheimer would be amazed at how interested we are in this disorder at this point. When he was a young psychiatrist working in an asylum in Frankfurt, Germany, at the turn of the last century, he met a woman named Auguste Dieter. She was admitted because she had memory problems, and more importantly, as I'm going to talk about later, she had behavioral issues. She spent her last few years in the asylum in Frankfurt, and just serendipitously, one of Alzheimer's friends, Franz Nissl, was experimenting with new microscopic stains that would reveal things in the autopsy material of the brain that had never been seen before. Next slide, please. So what he saw in the brain was, you can see at the upper level is what we call senile plaques, which are accumulation of dead cells and debris. And then at the bottom, neurofibrillary tangles, which are inside the brain cells themselves and have to do with a disruption of the internal architecture of the brain cell. Over on the left, you can see the macroscopic changes in the brain, which are that it's shrunken and atrophied. And there's a lot of loss of the gray matter volume. This is Auguste Dieter, who we're privileged to have actual photographs of, and we have Dr. Alzheimer's records of his interview of her and her sparse answers and repetitive answers to the questions that he asked her. Next slide, please. Now, since Alzheimer's observation of the material from her brain, which revealed those plaques and tangles, 100 years of research has explored what makes those plaques and tangles and whether they're the cause of Alzheimer's or whether they're the body's way of reacting to something else like an infection. Even an infection from bacteria that inhabit the gums has been considered, or viruses that might remain dormant in the nervous system, or systemic inflammation, or poisoning from environmental toxins. Many different theories have been advanced, but the most research has gone into what's called the amyloid cascade theory, which hypothesizes that there's an abnormal protein that's produced in the brain that the brain can't get rid of, and it kills cells and accumulates, destroying synapses and killing brain cells. One of the strong supports for this is that we know that people with Down's syndrome produce a lot of this same protein, amyloid, and by age 35, many of them show plaques and tangles in their brain, and by age 60, the majority of them have Alzheimer's disease. There are other lines of evidence that point in this direction, and it's led to the most common therapies, which I'll talk about later. Next slide, please. One of the important things that we know about this disease process is that it doesn't happen overnight. People don't develop Alzheimer's suddenly, although they might appear suddenly to have changed, say after an operation for a hip surgery or something of that sort, or a fall. But now we think, over the past 10 years, we've kind of redefined our idea of Alzheimer's disease to include 3 stages. The first stage, which goes on for 10 or 20 years, is what we would call preclinical Alzheimer's disease. And the only way that we would know that somebody has this disease is if they die of some other cause, and we do an autopsy, and we see that there are plaques and tangles, but they had no clinical symptoms. Now, these days, we also have blood tests and scans of various types that could tell us important things as well. I'll get into that a little later. Then there's that second stage, the mild cognitive impairment that I talked about, where people are symptomatic but still functioning well. And then there's the third stage, which now we call Alzheimer's dementia, leaving the idea of Alzheimer's disease as the pathology, the changes in the brain, and the dementia as the clinical syndrome. Next slide, please. We can also divide the Alzheimer's dementia into 3 phases: an early phase, or mild, a moderate or middle, and severe or late. And the changes that occur, if you've known somebody who was affected by Alzheimer's, evolve during the course of these 3 phases. At the beginning, it's pretty easy to work with somebody who has mild memory problems or language problems, or sometimes changes in behavior that are easily dealt with. In the middle phase, people start to need much more help taking care of their basic physical functions, and these deteriorate to such an extent in the later stage that a person becomes totally dependent for feeding, for toileting, for dressing, for bathing, and may not be able to communicate well. Next slide, please. We can watch the development of this disorder in the brain now by using scans that look for the proteins that I talked about before that affect plaques, that's the beta amyloid, and tangles, that's the hyperphosphorylated tau protein. And what we're looking at here on the left is an MRI of the brain. And you can see that there's some atrophy or wasting of the brain if you know how to read these things. On the right, what we're seeing is some interesting colors that represent radioactive signals sent out from the brain after we've injected tracers that bind to special parts of the brain. In the upper one, what we're looking at is what's called a amyloid PET scan. PET is for positron emission tomography. When we inject a special tracer molecule solution that binds to the amyloid deposits in the brain, we see these red or hot spots light up in the brain, showing us that a person with Alzheimer's has amyloid accumulation. Now, previously, we relied on a different type of scan, a glucose scan called FDG PET, fluorodeoxyglucose, which looks for where the brain is using glucose to make energy. In other words, where it's metabolically active and working. And what we can see in the bottoms on the right is that blue or cool area that shows little metabolic activity corresponding to the same areas that we saw the amyloid depositing in. So in other words, the brain collects amyloid and stops working. Next slide, please. And we can watch this change during the course of the disorder. Now, I want to mention the part that isn't as often talked about by neurologists and even sometimes psychiatrists who make the diagnosis of dementia, but it's very, very well known to families and to those who love and care for people with cognitive disorders, which is behaviors. 90% or more of people with dementia develop behavioral problems. And to my mind, the behavioral problems are the most important part of dementia because, quite frankly, people can live without much memory, but they can't live with aggression, self-injury, inappropriate behavior, wandering, and so on. So when we look back at Alzheimer's index patient, Auguste Dieter, what we learn about her is that besides the memory difficulty, she had very disordered behavior. She was screaming, paranoid, accusing her husband, hallucinating. And this is why she had to be institutionalized and met Dr. Alzheimer. Next slide, please. There wasn't much that they could do for people with those problems in those days. Today we have a few more tools, but it's still the big problem in Alzheimer's and other dementia treatment. Early on, we might see changes in mood. In fact, some people become depressed even before they become cognitively impaired. This happens with Parkinson's dementia, Lewy body dementia, frontotemporal dementia as well. Sometimes we see changes in mood preceding the cognitive changes. That's okay. Then there's changes in thinking, which include suicidal thoughts, sometimes beliefs. One of the common beliefs we call the phantom boarder syndrome, where a person is convinced that somebody who shouldn't be there is living in their house, the attic or the basement, or staying out of sight during the day and wandering in and taking things at night, eating out of the refrigerator and so on. This idea that somebody is in the house that shouldn't be, very common and frightening problem for people with dementia. And I've known people to stay awake all night holding knives ready to protect themselves and protect their spouse and be ready for an intruder. Unfortunately, sometimes there can also be misidentification and violent behavior, sometimes suicidal behavior. And these kinds of things make it very, very challenging for a family to keep somebody at home, which is what we often want. We so often hear people say, whatever you do, never put me in a nursing home. Of course, that's what they say before they're the person who might need a nursing home. This might be a question that some of you have about how you deal with those promises that we make to our elders about home care, which at some point might become really dangerous and impossible. So next slide, please. And especially things like wandering. Every year, a certain number of people actually freeze to death because they've wandered from their homes in winter, not dressed properly. Now, I do want to mention just briefly, because everybody's interested in this, when it's not Alzheimer's, which is about 2/3 of people with dementia, what could it be? Well, the good news is that about 10% of people, perhaps, who come to a memory disorders clinic with problems have a reversible condition. Most recently, we look for what's called long COVID or late COVID complications. About half or more of people who have COVID infections, even mild ones, are left with some cognitive changes, usually a milder brain fog or trouble with language or memory or energy. And that can dissipate and improve over a course of months, usually, sometimes a little longer. We don't really know the full story yet because it's only been a few years that we've been living with COVID. It may be longer for some people. In any case, that should be reversible. Vascular dementia, and there are other reversible conditions too, like sleep problems, depression, medication interactions when a person has, with all the good intentions of their physician, been put on a lot of medicines which don't agree with each other. Alcohol is another thing that we should be able to help. And then there's some things we can't help quite as much, like dementia with Lewy bodies, frontotemporal dementia, and some of the genetic or infectious dementias. Next slide, please. And I'm glad to answer more questions about those if you like. Next, we'll go on. This just shows a stroke, but you can't really see it very well. After stroke, some people have dementia. Next, please. And then here we see in the frontal part of the brain, particular localized atrophy. Frontotemporal dementia is important for us clinically because people with this problem often get referred to a psychiatrist rather than a neurologist, with the idea that their behavior has changed even before their memory. Next slide, please. So it's one of those confusing disorders. Among young people, the most common cause of dementia is alcohol. And so one of the things we know is that drinking more than a drink or two of alcohol a day really can produce long-term cognitive changes that ultimately can lead to dementia. It's an area that's still being researched because alcohol use that's very heavy is often also combined with nutritional deficiency or head injuries or other problems that contribute. Next slide, please. And then head injury, traffic accidents, falls. Those are the most common ones. And of course, they're combat injuries. Next slide, please. Next slide, please. And the next one. And HIV in a number of people will also be associated with an infection-related cognitive change. So the next part of what I'm going to talk about then is what can we do to be helpful? And the first thing is prevention. I'm going to talk about that, and then I'm going to talk about detection, treatment, caregiving, resources, and last I'll talk about research. So first, about prevention. I've put, well, this is a slide which shows an interesting thing here. I just want to focus here on the upper line, which has to do with the accumulation of beta amyloid in the brain. 0 is the time at which a diagnosis of dementia was made. This negative 30 means 30 years before. And the reason I show this slide is because it shows that the development of amyloid accumulation, which causes the disease in the amyloid cascade hypothesis, takes about 30 years, whereas the clinical symptoms appear much later. That, I think, is very optimistic news because we have a lot of time during which we can intervene. And the World Health Organization says, based on accumulated research, that probably 30 or 40% of cases of dementia could be delayed or even prevented by healthier lifestyle decisions. Next slide, please. So I'm going to talk about that. I put all of the evidence-based lifestyle changes into a mnemonic so I could remember when I give talks, and it's dancers. Let me talk about what that means. D is for disease management. Only about half of people with high blood pressure are adequately treated. Many people with diabetes are not adequately treated. These are two very important diseases that affect the brain in a damaging way. Sleep disorders, including apnea, where people don't breathe at night and make their brain deprived of oxygen and energy function. That's another important one that we often pick up in our clinic. And treatment of these kinds of diseases can protect the brain, especially we worry about during the 50s, 60s, 70s to create healthy 70s and 80s and 90s. Depression, medications, substances like alcohol, these are other things that we can reverse and change. Well, there's still plenty of time to have an effect. Next is activity, and I use the word activity rather than exercise, although we always hear that exercise is very good for the brain. In my opinion, activity and exercise are the best medicine that we have for the brain. And it's recommended that as adults we exercise 30 minutes of aerobic exercise 5 days a week, or 20 minutes of vigorous exercise 3 days a week. But only about 10% of people over 75 actually achieve that. It's a very important thing that I always try to communicate to our patients and to my colleagues, that we need to talk to patients about that exercise is very, very important. It improves energy metabolism, blood fat levels and cholesterol, use of glucose, insulin sensitivity, blood pressure. There are many things. It's a whole talk on its own. Living an active lifestyle means more than just making the time for exercise, though. It means not sitting at your desk all day, but getting up, taking a break. I like to get up, do a few push-ups, make sure that I walk up and down the stairs a few times if I can. Everybody has their own routine, but it's important not to neglect that during the day and save it just for exercise. Nutrition. What we've learned about nutrition is that the Western diet has some damaging features. High caloric intake. You go to a restaurant and you get enough food for 2 meals. If you eat that way steadily, that can't help but increase our weight, and obesity is very common in our population. Obesity brings with it systemic inflammation and insulin resistance and other problems that are very damaging to our brains as well as the rest of our body. The Mediterranean diet is often recommended for its high fiber content, low saturated fat, modest caloric intake, and fresh fruits and vegetables. Those are all good. Avoiding red meat, to some extent. It doesn't mean you never can have red meat, but fish and poultry are healthier forms of protein, and then of course they're plant proteins that we can eat. Cognitive stimulation. A lot of times people will ask me, is it good for me to do crossword puzzles? And I think it's always fun. I love doing the Wordle, for example. People have been discovering that lately. The New York Times Spelling Bee is a lot of fun. Word puzzles, crossword puzzles are great exercise and pastime. If given a choice between taking a walk and doing a puzzle, I would choose for the walk because it's better for the whole body in which the brain lives. But when you come back from the walk, sit down and do a puzzle, especially if you can combine it with the next one, which is social engagement. Many puzzle activities are suitable for interpersonal collaboration, like working on a jigsaw puzzle together, doing a crossword puzzle together with somebody. Those are good activities that engage in social connection, and social connection is very important. We're very social beings, biologically as well as psychologically, and it's been shown that people who are lonely or isolated have a higher mortality rate, don't heal as well, have a greater likelihood of dying after surgery or a myocardial infarction, for example. Next is relaxation. Important to make time to unwind. That Mediterranean diet glass of wine is one way that people do it, enjoying that relaxation and company. But there are a lot of other good things like meditation, mindfulness practices, yoga, tai chi. All of these are good. And then the last one is sleep. And I know in my life I've struggled to make time for sleep. Sleep should occupy a third of your day, 8 hours. And for many of us, we borrow from our sleep hours in order to get enough things done during the day. But that's not healthy. In fact, early in my career, I met an interesting man, a professor emeritus from a big institution, who told me how proud he was that he'd accomplished a great deal in his career principally by getting the edge of learning not to sleep as long as his competitors. He started by teaching himself to sleep 6 hours a night, then 5 hours a night, then 4 hours, and 3 and 2, and he slept about 2 hours a night when I met him. When I met him, he had pretty severe Alzheimer's disease. I don't think it was an accident, honestly. We know that if you deprive a person of a one night's sleep, they have a higher level of amyloid in their blood the next day. And that's thought to be because the brain has its own kind of renewal system called the glymphatic system, which bathes the brain cells in cerebrospinal fluid during the night, during deep sleep, and cleans away some of that amyloid. It's very important to get that part of sleep, which many of us don't. There also are sleep-related breathing disorders, which many people don't realize. I'll ask my patient, do you have trouble sleeping? And they'll say, well, I seem to sleep okay, but I'm tired often during the day. Do you snore? Well, I don't know if I snore. I'll ask the wife of the husband, does your husband snore? Well, I don't know. I sleep in another room. Well, why do you sleep in another room? And then you find out about the snoring. Next slide, please. Okay. So in terms of how we can manage the problems that cognitive impairment raises for us, the first is being aware. And you know, they say in the airport, if you see something, say something. Many of us are reluctant to express concern to people that we see having problems, whether it be with alcohol, stress, depression. But memory problems fall into that same category. We can show our love and care for others by having a frank discussion with them if we see that they're having difficulty. For example, I remember when my father went through a red light and hit something and destroyed his car. And my brother, who loved my father so much, went out and bought him a new car. Instead of getting his driving tested to find out whether he was habitually making mistakes in his driving, we had to get him tested, and we found out that really he wasn't capable of driving anymore. As difficult as that was, and it was quite difficult, it was the right decision. As a doctor, sometimes I have to send people to the Department of Motor Vehicles to get tested. Nothing makes them angrier. All of us doctors get reviewed. My reviews are 5-star and 1-star. The 5 stars are from the people who liked what I did. The 1-star from the ex-drivers, unfortunately. We live with that. There are wonderful screening opportunities available, one of which is from our own program. We call it the Memory Ambassadors. And you can look on the Christiana Care website under the Swank Center or look for Memory Ambassadors. We go out either virtually or soon again in person to community groups, churches, senior centers, assisted livings, and we do a lecture on memory and then free confidential screenings for anybody who's interested, just like a blood pressure screening. And then we talk to your primary care if you want us to, if there's a problem. And sometimes that's reassuring for people or a good way to alert them to a problem being there. In terms of screening by doctors, over 65, we're supposed to have an annual wellness visit under Medicare. And part of that annual wellness visit is a question about cognitive functioning and a screening. And so that should identify for some people if there's a problem. But it's important to keep in mind that an older person with memory problems may not recognize that they have that problem. I always say, if you have chest pain, you squawk about that. You go to the emergency room. We all know how dangerous that can be. If your face suddenly droops and you have trouble speaking, that might be a stroke. You get help right away. Even if you have, there's so many things that we, tooth pain, we go to the dentist. But memory trouble, we say, somebody took my keys, I didn't lose them. Memory trouble is really threatening and also difficult to detect in yourself. So if you go with your spouse or your parent or your loved one to the doctor, you can make them aware, or you can even call them and let them know that you have that concern, or write them a note. We don't mind getting notes like that. There are specialists as well. In Delaware, there aren't a lot of specialists. In fact, I think I'm going to be interviewed next week about the new Alzheimer's facts and figures. One of the interesting pieces of information in that new report from the Alzheimer's Association, is that they're calling Delaware a neurology desert, that there aren't enough neurologists to deal with the aging population with dementia. And that's true for geriatric psychiatrists like myself as well. There are only a few, and so this is an area where you might need to look a little bit to find a specialist. Two in this area are the Swank Center at Wilmington Hospital and the Jewish Family and Children's Service COMPASS program, which is excellent as well. There are simple tests that can identify the presence of a cognitive difficulty, and then more extensive medical workup to make sure whether it's something treatable or how we would treat it. And then the treatments fall into two categories, basically: the non-medication ones that have to do with protecting safety, making plans for the future, providing supports that help a person function at their best. For example, living on one level, having somebody come in to help with meals, no longer driving, getting transportation help, having somebody help with medications, and so on. And that can progress to the point where a person needs to live in a facility where they have 24-hour care. And then finally, there are some medications. And the medications help a little bit with the cognitive problems and help perhaps a little bit more with some of the behavioral issues. The medicines are no free lunch, All of them have side effects. Their ability to help is limited, but sometimes they make the difference between somebody being able to live at home or not. Next slide, please. When we have a loved one with a neurocognitive disorder, the word that I hear from them about what they want most often is respect and dignity. Respect, really, two words, respect and dignity. Inside the body of this person who can't remember even sometimes who you are is still a very active emotional life in many cases. And people are easily hurt, they're sensitive, they're ashamed of their difficulties if they're aware of them. If they're not aware of them, they're irritated at you perhaps for pointing it out. Life is very difficult for a person with dementia. They have to work much harder just to do the simple things like understanding what somebody's saying to them. They may end up sleeping more, withdrawing from social activity, doing a lot of sitting. It's important to keep them engaged and active and provide them with a respectful environment. We need to make plans early on about their job if they're still working, about their driving if they're still driving, protecting them from financial exploitation and scams. And in Delaware, we have a special investigator in the Department of Justice, Craig Weldon, who is available to everybody and has helped with many of our patients. And but we also have the Elder Protective Services, which can intervene. We want to make sure that people have made a will and made plans in an advance directive for the future, thought about their estate, where they're going to live, and protected their home from dangerous things that might make them fall, for example. Next slide, please. And then, as I mentioned before, sometimes they need either somebody moving in with them or need to be in a safer place. Anybody who has dementia and people caring for them has been the cause, although they certainly don't want to be, of another problem which is related, which is caregiver burden. And taking care of somebody with dementia is one of the most difficult things a person can do. If you take care of somebody with cancer, they're still present in an emotional and cognitive way and understand what you're doing and collaborate with you and appreciate you in a way that isn't always true of somebody with dementia. They may not know why you're there, why you're trying to change their soiled clothing, why you want them to take a bath when they swear that they just had a bath, or take their pill when they don't want to take a pill. It's really difficult and puts a person at higher risk for developing depression themselves. So we want to make sure that we support people who are caregivers. There are peer groups, therapists who specialize in this, and a 24-hour hotline for the Alzheimer's Association, which is very good. For the person with dementia, sometimes we can take advantage of supports in the community like peer supports at an early stage, senior centers where they can go and do activities and be around other people. Later on, there's adult day program where they can spend a large portion of the day with people who understand their deficits. And then eventually they may need respite care, which is temporary care in a facility, or more permanent care. I put here Department of Justice and Adult Protective Service, which I already mentioned. One interesting prevention step is what has been called the Brain Gym or the Brain Fit Club. Next slide, please. Since we know that cognitive stimulation, diet, social engagement can be very helpful, there have sprung up around the country programs for providing these things. And all of this was greatly reinforced by a study done in Finland with a couple thousand older adults who were cognitively normal, who engaged in a program like this for a couple years and made measurable gains in their cognitive functioning, even some with early cognitive impairment. At Beth Israel Deaconess Medical Center in Boston, there's what they call the Brain Fit Club, which is a place where people go and they can participate in groups, Tai Chi, special cognitive stimulation groups. They can get dietary advice, education about sleep, meditation. And I actually tried to get something like this started in Delaware. I haven't succeeded yet, but there are programs in some of the senior centers that provide ingredients of this type of program. Next slide, please. That may bring us to the end of my formal presentation. But I'm open for whatever questions or comments or special interests that you might want to bring up. Yeah, this last thing is just about research, that there are some amazing new scans, blood tests, and possibly even medicines in the pipeline for us. Yes, sir, in the back. Oh. Genetics definitely plays a part to a greater or lesser degree. Now in Alzheimer's, I would say it's to a lesser degree, although not gone. Let's start with where it plays the most important role, which would be in something like Huntington's disease, which is a autosomal dominant gene. If somebody has Huntington's, half of their children are likely statistically to have it. With Alzheimer's, it's much less dominant. It's probably polygenic, which means having to do with multiple gene inheritance, and lifestyle is probably at least as important for almost everybody who has later onset Alzheimer's. There's a small number of people with onset of Alzheimer's before 60 where it is autosomal dominant and has to do with a genetic mutation in that amyloid producing process. But for most of us, we shouldn't really worry that much about the genetics unless we have 3 or more relatives who had Alzheimer's before age 60. And behind you.
Can we, if you're going to, let's wait for put on the mics so the people at home can listen. So.
Oh, yeah.
Go ahead.
Has the spread of and usage of electronic media had any effect on the mental processing that everybody goes through on a daily basis?
Great question. I'm just going to repeat it because it was a little quiet here at least. Has the spread of electronic media affected Alzheimer's in some way? And there are a number of ways in which it has. For one thing, there are assistive devices like home fall monitoring systems that rely on electronics that have made it safer for people to remain at home. Automatic pill dispensers, other uses of electronics. But in terms of social media, I would say it's played its most important role during the past few years with the pandemic, because many people who lived in assisted living facilities or nursing homes actually for a while were confined to their rooms and unable to have visitors, except, for example, window visitors or visitors via an iPad or a computer through social media or Zoom or FaceTime. And so I would say that social media have been a lifesaver during the past few years. Social media is a great way of keeping us connected, but it also, as you know, and I assume this might be part of the reason you're asking, is it's a way of isolating us too. And people who are more isolated are more prone to developing cognitive difficulties and medical difficulties. But I think social media is either valuable or not so valuable depending on how it's used. For example, if we use social media to compare ourselves unfavorably to others who have more polished Facebook pictures or tell about their great accomplishments and successes and make us feel deficient in some way, that hurts. But if we think about liking and approving and responding and applauding the good things we see, or laughing at the funny jokes that come over social media, or enjoying the impressive scenery videos or other interesting things, it can be a source of stimulation and learning too. Does that address your question?
Okay. Thank you.
I noticed Tai Chi is popping up in a lot of these interventions. Is that for a specific reason in terms of, has there been research that indicates that that's helpful?
There has been research that indicates that Tai Chi is helpful both physically and cognitively. Personally, I found Tai Chi a little slow, and so I took a few classes. I had a good friend who progressed very far in it, but I was interested in more speedy types of physical activities. But what I love about Tai Chi and what I think is very helpful about it is it works on memory because you have to remember the form. It works on attention because you have to focus on what's going on around you. It's visuospatial, of course, because you're moving in space. It helps you with balance. It's bilateral, and it's calming. So for all of those good reasons, it's an incredibly helpful exercise. And I know people who swear by the value of it, as well as research has demonstrated that. Uh-huh. Yeah, I think it deserves to have a following. Yeah, definitely. Yes.
Hi. In recent years, we've been caring for aging parents, one with dementia, one with physical decline. And one of the most difficult things, I think, was full body care. Finding, geriatricians don't seem to be abundant in the area. And I guess I'm just curious as to that specialty, how the typical family physician might not be able to deal with all of the issues of an aging body and mind, right?
Yes, that's right. Now, in Delaware, we're something of a retirement haven and a prized retirement destination. So in Newcastle County, over 16% of the population is 65 and above. If we go down to Sussex County, it's over 25%. So there are a lot of older people in Delaware. Geriatric internal medicine or family practice is a specialty that has not historically attracted enough people. Perhaps it's not as well paid as being a thoracic surgeon or a neurosurgeon. It takes a special kind of person who really enjoys working with complex medical problems and elders. It's a wonderfully fulfilling profession, and I have to say that the geriatricians that I know are less stressed and happier people than many other medical specialists. But it takes a special kind of person to do it, and in Delaware, as I understand it, there are only 18 geriatricians. So that's certainly not enough to serve the state. I'll get to in a moment. Geriatric psychiatry works alongside geriatricians and complements their work on behavioral issues. At Christiana Care at Wilmington Hospital, we do have what we call the Geriatric Consultation Program, which is part of the Swank Center in the Gateway Building. And Dr. Lindsay Brandt there will do a consultation that's kind of a overview and assessment of a person's medical problems. But the bulk of care of older adults is in general primary care by primary care physicians who are more or less knowledgeable about the diseases of the elderly. Many of them very knowledgeable, but not all of them, of course. Yes? A little louder, please. Yes, so Alzheimer's is a type of dementia, the most common one, the same way carrots are a vegetable. Dementia is acquired cognitive impairment sufficient to impair independence, let's say. And Alzheimer's affects about 2/3 of the people with dementia. There was, yes.
Jim, I have a question, and then
Yeah.
I want to give you a leading question to allow you to elaborate on some things that you and I have in common outside of this.
Of course.
First of all, any relationship between statins and Alzheimer's? And secondly, would you comment on why it would be really helpful for people to play instruments or to sing in choirs or to attend Delaware Symphony Orchestra concerts to improve their cognitive ability?
Yeah, I'll address both of those, and they're both topics dear to my heart. Statins are among the most widely prescribed medications in the world. And the reason that they're prescribed so widely is because they do have benefits in stroke prevention, but not everybody benefits from them, and some people actually experience side effects. And one of the side effects that some people have experienced is cognitive slowing and difficulty thinking, like a brain fog. It's not a dementia, and it doesn't seem to be a precursor to Alzheimer's or to increase the likelihood of Alzheimer's. There's some research that looks at statins. Generally, this is a reversible problem. If you stop the statin, just like the muscle cramps that some people experience go away, the brain fog should go away. So I'm not too worried about statins being harmful over the longer term if a person recognizes that it's not the right drug for them, and there are other ways of managing cholesterol. Now let's talk about music. I probably should have even mentioned that music is one of the most helpful cognitive activities. And like Tai Chi, it involves memory, concentration and attention, social interaction. It engages the emotions. It involves so many functions. And if you're playing it, it involves, coordinating your body and your mind and your feelings. In my own outside life, I'm very active as a chamber musician, always have been since childhood. Love it and feel like it's incredibly helpful. I have to say, I rarely see music teachers coming to the Swank Center. I think they're some of the most cognitively preserved older adults that I ever run into, musicians and music teachers. And
I'd be remiss if I didn't say that we have openings in the choir.
yeah. So I certainly recognize as one of the cognitive activities that a person can do, learning a musical instrument is great. And of course, attending the Delaware Symphony is important too. Yeah. Yes?
Could you address more about the hearing loss and dementia?
Yes. So hearing loss is not an uncommon complication with aging. And what I said about hearing loss before was that a person who has hearing trouble tends to compensate by withdrawing or tuning things out if they don't like the way that the hearing aid feels. So the World Health Organization has identified that a small but significant percentage of what they call population attributable risk for developing dementia, which means if you could improve hearing in the general population, you would reduce the incidence of dementia by a small percent, but significant. Yeah.
And this may seem like a silly question, but every night during the news hour, there are commercials for Prevagen.
Oh, yeah.
And testimonials about how their memory is sharper after taking it. Is there any truth to that?
Well, I hear those same commercials, and I get asked the question about Prevagen in particular because it's very widely advertised, but other supplements, if you go on the internet, you can see that there are hundreds of supplements advertised. Many of them have a bunch of ingredients, each of which on their own has some possible benefit, but often given together in a pill with such a low dose that it probably doesn't have much benefit. Prevagen is a little different. It's a synthetic version of a protein called equaporin, which is found in jellyfish. So when I'm being dismissive, I say, well, how smart are jellyfish? But on the other hand, they do have some, capacity to survive under harsh circumstances. Maybe they're not to be dismissed so easily. And that doesn't mean that it wouldn't be helpful for the brain. You do hear people saying, you know, it's helped me tremendously, but the Food and Drug Administration actually sent the manufacturers of Prevagen a warning letter and told them that they really were advertising beyond what was evidence-based. When I looked at the research, I was not impressed. And like many research that supports these proprietary mixtures of different things to help with various conditions, it wasn't research that I think was designed well, and it was supported by the manufacturer rather than an independent agent. So I wouldn't necessarily recommend Prevagen in particular, or supplements in general. There might be a few supplements that are exceptions to this. If you're vitamin deficient, it's very important to take vitamins because the body doesn't make them. B12, D, these are two that we, and folate, these are three vitamins that are often deficient in older adults and can affect cognition. Some people like to take ginkgo. That has some benefits and some risks. You should consult your doctor. Some people take omega-3 fatty acids. It's still controversial whether those are beneficial. In a large study of people with dementia, they didn't help. In a group of people who were not demented, it seemed to reduce the number of people who became demented. So, you know, it may or may not.
Any other questions for Dr. Ellison today? Well, thank you very much. We really appreciate you coming and sharing this information. For everybody here and online, we will be posting this presentation on our website, so if you want to look at it again or have friends, family, neighbors who want to look at it, they will be up there too. Thank you very much, Dr. Ellison.
My pleasure. Thank you for giving me some of your time to talk with you about this.